What is menopause?
When do the cycles come back? Such a massive and important part of basic human physiology.
Seriously, bless your heart.
It's not very helpful to go, oh, I'm in menopause when it's been going on for a year. On this channel, we talk a lot about periods, pregnancy, and everything in between. But what we don't talk about enough is what happens after the periods, pregnancy, and everything in between. Menopause and the people who experience it are getting more and more attention these days. And you know what? It is so well deserved. But Halle Berry screaming, I'm in menopause from the steps of the US Capitol.
I'm in menopause! Okay.
And 25, 60 to 70-year-olds taking reality TV by storm last fall on the Golden Bachelor is just not enough.
Never have I ever been with a woman sexually.
Can we have another pint of ice cream over here for Susan?
You all have been begging for more content on menopause through my comment section, and you know what? I agree. So let's talk about it. What is menopause? What should we do about it? Let's jump into it. As always, I am a doctor, but I'm not your doctor. This information is for educational purposes only and meant to serve as a building block for things to bring up with your own doctor or advanced practice provider. Before we jump into all of the information, let's watch Viola Davis on Jimmy Kimmel explaining to him what is menopause.
I know this is going to sound like a very stupid question, and it is a very stupid question, especially for a man my age.
No, go ahead, hit me with it.
What is menopause? I mean, I've heard of it.
I've heard of it.
You know what? Menopause is hell.
It is.
Jimmy.
Is it really?
Menopause is a dark hole. Okay, that's what menopause is, and that's where I'm at right now.
Oh.
So I either will love my husband today or kill him today.
Oh, no.
She's so funny and so beautiful. My God, she looks gorgeous.
How long does it last?
You know what? Somebody needs to tell me.
Hold on, throwback. Can we please all, if you've been here for a while, remember the time that Dr. Mike pranked me by calling me on my personal cell phone and telling me he had a medical question and asking me, when does the menopause stop? As in, it's a pause. When did the cycles come back? Cue me trying to be respectful while losing my ever-loving trying to figure out how a seemingly wonderful family practice doctor had missed such a massive and important part of basic human physiology.
Literally, I'm telling you nonsense about the menopause being a pause and restarting, and you're telling me medical exclusions where it may happen? Seriously, bless your heart.
All right, time to get serious. What is menopause? Menopause is, by definition, a retrospective diagnosis, meaning you can only really know you're in menopause when you're looking in hindsight. And that's because menopause, by definition, is going 1 full year, 12 full months without a cycle and without it being attributable to anything else. The problem with that is that it's not very helpful to go, oh, I'm in menopause when it's been going on for a year. So we have to have a little bit of information regarding what happens during menopause and the transition to menopause in order for this to be useful information. The average age of menopause is around 51. So obviously that means some people go through it several years earlier or several years later, but that's the average age. Perimenopausal transition or perimenopause or the menopause transition, many names, typically starts about 4 years before the final menstrual period, which is the last menstrual cycle that somebody will have in their reproductive or late reproductive years. Usually after about the age of 40, we start seeing cycles start to be a little bit shorter. And the reason for that is that this follicular phase, which is the first half of the menstrual cycle, shortens just a little bit and you ovulate a little bit earlier than you would have maybe in your younger reproductive years. So that's kind of the first sign of the menopausal transition. But this can go on for several years. You also tend to see after that cycles becoming more and more irregular, and eventually you will see the time between cycles lengthening because you're ovulating less frequently. That's kind of the late menopausal transition. In that late menopausal transition, you'll also see cycles tending to become quite a bit lighter and shorter. So the overall menopausal transition is Early on, you see cycles being a little closer together because that follicular phase is shorter. And then as you move into later menopausal transition, they actually become further apart because you're ovulating less frequently and less reliably. And the cycles become quite a bit shorter and lighter for most people. So I usually tell patients, if your cycles are becoming more irregular and a lot heavier, that's a reason to come in and talk to me. And if you aren't sure if what's going on with you is normal, you should talk to your doctor or advanced practice provider. Basically, the etiology or the reason this happens is because the ovaries stop making follicles that ovulate as oocytes, and that changes up the hormonal feedback loops, like what you see here, quite a bit, and you stop having periods. And the lack of periods is because you don't have an ovulation. There is a lot of information out there about how long that lasts, how often people have symptoms, who has symptoms, if everyone has symptoms, how long the symptoms last. And the truth is, it varies by person. Some people won't have any symptoms. They just get super lucky. But most people will have some symptoms. And the symptoms kind of come on a spectrum. Some people's will be fairly minimal and manageable without medications. And some people's will be really severe, even with medications. And they can go on for even up to 20 years, which is not something that we used to think could happen. We used to tell people that after you go through menopause, it should be just a few years and eventually those symptoms will go away. But we found that that's probably not quite true. So what are the symptoms? The most common symptom that people experience in menopause is something called vasomotor symptoms. You probably know this as hot flashes. 80 to 85% of people in the perimenopausal transition or after menopause will experience hot flashes. They're more common at night than in the daytime, but they can happen anytime. Some people will just have one or two a week, and some people will have them all the time throughout the day and night. And they can be incredibly problematic when they are that frequent because they can really interfere with not only someone's quality of life, but really your ability to even participate in your normal life, particularly if they are frequent and severe. So what is a hot flash? Essentially, you will see it mainly described as people saying like they start getting a heated feeling in their chest, and then that eventually spreads throughout the body, often paired with a sense of anxiety, being overheated, sweating, and that typically lasts 2 to 4 minutes. Obviously, individual experiences will vary, but that's typically how people will describe it. If they happen at night, most people will describe them as night sweats or waking up with just a sense of anxiety and being in a puddle of sweat and just feeling very overheated. Sometimes they tend to really centralize so that heat that starts in the chest for a lot of people may not spread throughout the whole body. It might just spread to the face and the ears might turn red. It's different for everyone, but I think the easiest way to describe this is the same as we often describe contractions is if it's happening, you will know that it's happening, and the definition or me describing it is helpful only in that maybe other people might get a sense of what it is so that they can be hopefully sympathetic to people around them. The second thing that is fairly common in the menopausal transition and during menopause is bone loss. Estrogen is a very important hormone for bone density as well as cardiovascular health or heart. So you see an increase in drops in bone mass and cardiovascular risk in people who are in the late menopausal transition and menopause. And the reason for that is fluctuations in hormone, mainly that great decrease in estrogen. So this is the period of time where you should start talking to your doctor about if you need to be screened for osteoporosis with something called a DEXA scan, which is basically an x-ray to look at your bone density, and other things that you can do to support your bone health, like vitamin D, calcium, regular exercise, or whatever your doctor or advanced practice provider recommends for your situation. Another common symptom that people experience in the perimenopausal transition and menopause is sleep disturbance. Often you will hear people talking about having trouble going to sleep, having trouble staying asleep, even if you don't have night sweats. This is something a lot of people describe. And like Viola Davis explained, people often will feel like they have trouble maintaining their weight or that they have more mood lability. These are really common symptoms that people experience. But again, not everybody will experience all of these. And some people get lucky enough not to experience any of them. Along the lines of the mood lability, an increased incidence of depression is really fairly common in the early menopausal years. People who have had a history of depression are at an increased risk of a recurrence, and even people who've never had a history of depression are at an increased risk of a new diagnosis of depression. So I think that this is an important thing for people to know about, because even though it is hormonally related, that doesn't mean we just go, oh, my hormones are changing, I'm depressed, it is what it is. No, we need to talk about it. We need to consider if you need to have treatment of some kind, either antidepressants or hormone replacement, both, counseling, whatever. Bring it up with your doctor, particularly if you have previously been diagnosed with depression, because that puts you in a higher risk category. One of the more common symptoms that people experience is what we in medicine call genitourinary symptoms. And this is basically vaginal dryness, an increase in UTIs, just general vulvar and vaginal discomfort. And the reason is estrogen is super important for healthy blood flow to the vulva and vagina, as well as really keeping the skin of the vulva and vagina nice and elastic and basically healthy and plump and hydrated and all of those things that we associate with being a little bit healthier skin. So when that estrogen level drops off significantly, you have an increased risk of vaginal dryness, both during intercourse or with sex, or just in day-to-day life. That can be very irritating. People might experience burning with urination. There's an increased risk of having UTIs. All of these things are related to the drops in estrogen and hormonal fluctuations. People will report all manner of other symptoms. I've kind of just gone through the most common and most significant ones that people have, but that doesn't mean if I didn't list it off in the discussion that we've had so far that it can't be a menopausal symptom. Anything from cognitive decline and changes, dementia, changes in libido, muscle mass and exercise difficulties. All of these things are definitely reported, definitely can be related. I just kind of wanted to go through the most common categories of what people experience. And now we'll move on to what do we do about it. In general, if symptoms are really mild, then you might be able to get away with just doing what we call lifestyle interventions. I'll put a little chart up on screen here as we go through this, but this is some of the effective lifestyle interventions for people who have really mild symptoms that are bothersome, but maybe not bad enough that they want to go see the doctor. People who have hot flashes and night sweats. If you smoke, this can make them worse. So if you are a smoker, quitting smoking might help. Other things that can help if you're just having occasional hot flashes is keeping a fan nearby. I don't know if you have ever seen those things. I used to use them when I played softball as a kid, but they're like these freezer packs that go around your neck. You can always get one of those to put on if you're having hot flashes that are relatively infrequent and not really interfering with life, but are kind of annoying when they happen. For sleep problems, good sleep hygiene practices are really important. So putting the phone away a couple of hours before you intend to go to bed, taking some over-the-counter melatonin or something like that if you feel like it would be helpful to you. Avoiding caffeine in the afternoon. People tend to be more sensitive to caffeine as they go through menopause. These are all things that may help with that, in addition to limiting alcohol intake, which interferes with that good REM sleep that you really need. For the depression, staying active, exercise, all of those things that we tell everybody for their mood. You can also make sure that you're in counseling and things like that. I don't really think if you are self-diagnosing yourself with depression and self-treating your depression that that's a great idea. So I don't love that this is included on here. I think if you think that you are depressed, you should probably bring it up with your mental health professional or your doctor or somebody, just so that you can get someone who has an objective view of this, because we don't always know where we're at until we're asked the right questions. For vaginal dryness, you can use a vaginal moisturizer. These can be really great. There's ones like Replens, I think KY makes one. There's all kinds of different ones at the store. Those can be really great. And then as always, a lubricant before and during sex. There's many different options for that. Unfortunately, most people who have symptoms will have symptoms that they feel like they would like more intervention than just those lifestyle ones. But I think the lifestyle interventions are helpful in that it's something you can do in the meantime until you get in with your healthcare professional. Estrogen is the best treatment we have for pretty well every symptom that people experience in the menopausal transition and menopause. So hormone replacement therapy. There have been concerns in the past, and I think that this will make a really good longer form video at some point about the history of menopause, as well as the treatment of menopause and the controversy surrounding it. Most of that relating to the Women's Health Initiative, which was a study that came out, I don't know, in early 2000s. And it kind of messed up everything as far as how many people are getting the needed hormone replacement therapy they should, because it was very hijacked by the media and misinterpreted by a lot of people. But what we know now, and what we know for sure, is that most healthy people who need assistance treating their vasomotor symptoms of menopause or other menopausal transition symptoms can take estrogen and or progesterone, which we'll get into how you decide if you need one or both, unless they fall into a few categories that would make them too high risk to do that. It needs to be started within 10 years of the onset of menopause, or before the age of 60, whichever comes first. So if you need treatment, it needs to be started in that time frame in order to be considered a safe intervention. I feel like I'm very animated with my hands today, like I'm making menopause potions. For those people who fall into that healthy, low-risk category, hormone replacement therapy with estrogen and or progesterone is considered safe and effective. So what are those categories? In general, and this is not an exhaustive list, so you need to talk with your specific doctor about your specific situation. If you don't have a history or not at significantly increased risk of having blood clots in the legs, breast cancer, heart disease, stroke, things like this, then you probably fall into a category where you would be able to use hormone replacement therapy. And when I say HRT in this section, I'm talking about oral or transdermal patches. Vaginal estrogen is in a bit of a different category, and we'll talk a little bit about that in a minute. Estrogen only versus estrogen and progesterone. Estrogen only is safer if you don't have a uterus. If somebody has a uterus, they need to be on both estrogen and progesterone, because the estrogen itself will build up that lining of the uterus and put you at an increased risk of endometrial or uterine lining cancer. So you can't be on estrogen alone if you still have a uterus. For people who've had a hysterectomy, estrogen alone is fine. Estrogen comes in many different formulations, tablets and patches. There are even some that combine the estrogen with whatever's needed for endometrial protection for people who have a uterus. And the progesterone can be either oral or combined, like we just said, or in the form of an IUD. I find people really feel very satisfied with the IUD. It is lower side effect. You don't have to take multiple pills a day. If you're on the transdermal patch for estrogen, you don't have to take any pills. It's very convenient, but obviously it's not right for everyone. Moving on to vaginal estrogen. If somebody comes in and their only complaint is vaginal dryness or recurrent UTI or pain with intercourse, this is likely related to genitourinary symptoms of menopause or low estrogen causing those skin changes that we were talking about earlier. Topical estrogen or vaginal estrogen is an incredibly safe intervention for this, and it is very effective. I really find that people don't bring this problem up with their healthcare providers as often as they should, and it's a shame because it is easy to treat. I think that we should be asking, and GPs or family practice doctors should be asking everybody who is over the age of 50 if they are having pain with intercourse or dryness or anything going on with the vulva or vagina related to menopause, because this is such a safe and effective treatment that I think everybody should know about it and have access to it if they need it. Again, not right for everyone. This is just general educational information for you to bring up with your own doctor. If you are not a good candidate for hormone replacement therapy, or you just don't feel comfortable taking hormones, there are other options. Different types of antidepressants, which are quite effective for some of the symptoms that people experience with menopause. And it's not because menopausal symptoms are in your head, it's just because these medications are also effective for this. I usually have to go through that spiel because I never want somebody to think I'm offering them this medication that's also used for depression for their menopause symptoms because I think their menopause symptoms are related to depression. That's not the case. Menopausal symptoms are very much a real thing related to hormone changes. We've just found that even super low doses of certain antidepressants can be quite effective for helping with some of those menopausal symptoms. There are other ones as well. There's a gabapentin and anti-seizure medication that can help, and some newer medications that are less commonly used, but there are options. So bring it up with your doctor or advanced practice provider, because I often find that people who would like treatment but are kind of anxious about the use of hormones just leave their symptoms and kind of suffer through it instead of bringing it up. So I just want you to know there are other options out there. In the next video that we do related to menopause, we will dive into the history of menopause and menopausal treatment, as well as the Women's Health Initiative. I think this will be a really, really interesting video. It may end up being a deep dive or long form. I don't know. We'll see how much we can find and how interesting the topic is. But I hope that you learned something today. If you have any questions, please leave them down below. If there's any topics that you would like me to cover in addition to what we're covering related to menopause, I would love to hear them. If you're new here and you're not subscribed, we would love to have you. I talk about periods, pregnancy, everything in between, and also, of course, now, everything after. Subscribe, and I'll see you next Monday.